This is just a prospective or a retrospective cohort study, actually, where we just identified patients who came into the epilepsy monitoring unit with a presumptive diagnosis of DSWAS, or we were looking for something called ESES, which is an electrographic definition of electrical status epilepticus in slow wave sleep. Depending on which journal you look at, some people say it's electrographic status epilepticus in slow wave sleep. There's even variation in what the acronym is. So we identified those patients that met criteria for either ESES, so that meaning they have greater than 85% of their slow wave sleep is taken up by spikes, or they have more than 50% plus something developmentally that kind of speaks to an epileptic encephalopathy. So if they were normally developing and then maybe had a regression or stagnation, or they already came in with developmental challenges and then maybe stagnated or took a step backwards, along with perhaps the onset of their epilepsy.
One of the things that kind of stuck out to me was the EEGs specifically in your study. So what can the features of the first EEG tell us about a patient and maybe help us distinguish what kind of patient they are a little bit?
Yeah, of course. I think the first thing is actually to have awareness that this entity exists so that you know to go and look for it in the first place, because it is a unique entity and that we can only diagnose it with an EEG, and specifically an overnight EEG capturing sleep, because these patients need to go into slow wave sleep. So what we're looking for is, we do know that there's abnormal electrical activity that might be happening sometimes while they're awake, but when they go to sleep, that activates. So sleep, it sounds counterintuitive, but is kind of an activating time for the brain, and things become more highly synchronized, and so sometimes sleep makes these discharges become more prominent. So when we see that, we know that they have spikes that are activated by sleep. And each center might be a little bit different in how they calculate what really is spike wave activation, but we know it's when there's a big percentage difference, maybe even 50% difference between wakefulness and sleep. And we use that EEG to then kind of say, okay, we're seeing these spikes more than 50% of the time, plus there's something clinical that putting that together, this means that they have DSWAS.